to you at the bottom, but it's mainly your screen.
Can you see the X-ray pretty good?
Yes. Yes.
Perfect. Let me know when you guys want to roll it, but I'm sure people are still trying to get on. We'll give it a few minutes.
All right. Yeah. We have about 27 people on right now. So
Nice.
yeah, I'm excited to see how this goes, because this could definitely be a good outlet for everyone and all schools, because I know kind of firsthand how much they try and make it a little harder for people. So at least we don't need to worry about getting approvals now, which is great.
Never been big on approval.
Yeah.
Marcos either, clearly.
Yeah.
Hey, congrats to you two, by the way.
Thank you so much. Thank you.
How are you feeling, Brittany? You got a lot of morning sickness?
No, I haven't been sick once. The worst part about it is being tired and my face breaking out.
Oh, man.
But other than that, I feel normal. I feel the same.
It's great. I've got a patient right now who's pregnant who has hyperemesis, where she just can't stop puking.
Oh, God.
But the adjustment's the only thing that helps her, so
Oh, wow.
good.
Yeah,
Keep her out.
that sounds horrible.
Yeah, it is bad.
What have you been adjusting on her?
Actually, Atlas is what helps her.
Oh,
Really? Okay.
She's got a nasty Atlas that goes out. Whenever it's out, it comes back. But every time we set it, she never gets completely nausea-free, but she stops vomiting. The whole problem with hyperemesis is when they start vomiting like that, they can't keep anything down. They a lot of times have to go get a PICC line in so they can actually be fed intravenously throughout the pregnancy. Depends on how long it lasts. My sister-in-law had that. She was basically IV fed for all 9 months.
Wow. That's a tough 9 months, right?
yeah.
She did that twice.
Really? Both times that happened? Wow.
Yeah. And my wife was sick for 4 months, but she never got hospitalized. We were able to, keep her home and stuff. But for 4 months, she just was sick and puking all the time.
Wow.
Yeah. So how's things going besides that? Everything else is good?
Yeah, not too bad. Just finished getting through our quarter. It's coming to an end this week. And then just being in clinic's a lot better than being in the classroom. So that's always fun.
Exactly.
How's everything with you been?
Good. Yeah, real good, man. Just the holidays are just such a busy time. So just trying to finish the year, man. Get into next year.
Oh yeah. That's great though. That's a great problem to have.
Hey, for you guys who are going to the extravaganza, for some reason, man, all the hotels are already booked up.
What?
So if you guys want to go, start looking for VRBOs and stuff right now, or figure out, because there's nothing in Mount. I mean, there's hardly anything in Mount Orb, but the Grand Stay is already sold out.
Oh,
Wow.
Yeah, and that's the dates are the April 30th through May 1st.
And they're already sold out. Wow.
Yeah, I think there's a lot of weddings and stuff and some other type of conferences that go on in that area, but Ben said that that's kind of been going on for the past couple of years, but this is the first time I've booked this far out and not be able to get a hotel, so it's weird.
Jeez. I think we're good to start whenever you want to get started, Doc. And then
All right, yeah, let's do it.
people
All
come
right,
in.
so first of all, Marcos, thank you so much for doing this. I mean, this is when you do Gonstead, I mean, you guys know that you got to go above and beyond to try to learn this stuff. You can't just think of what you get at school is going to prepare you for the work. So, you got to go out and you got to find doctors to teach and all this. And, when, schools try to put obstacles in your way, just like when we came down there, we didn't, I'd already booked the flights. I said, we're going to struggle to have the seminar. So you have to do what you got to do to learn what you need to learn. And this group that you started is just a great way. I mean, having doctors on to teach you guys, across the country and, it's just a great tool. So thank you so much for doing this. And I'm sure they're all appreciative as well. So what I'll be presenting on tonight, guys, is probably our biggest struggle in Gonstead, which is dealing with the chronic subluxation or the chronic patient. And just to give you a little background of where I'm coming from with this, most of the information that, I'll be presenting tonight, I learned from my mentor, Dr. Larry Landers, who recently passed away this year. But so a little bit about him. He was one of Gonstead's first students. He actually went to his first Gonstead seminar before he was actually in chiropractic school, back in probably around 1957 or 58. He graduated in 1961, but yeah, he was one of his first students when he started teaching seminars altogether. And just a really great Gonstead guy. And what makes him unique, though, is that Dr. Landers was very, very sick. He had, not sure if it was readers or whatever, but he had extreme bilateral sciatica. His organs and stuff were just kind of shutting down on him. So he would close his clinic about every 3 months and go up to Mount Orb and stay a couple weeks and get seen 3 times a day. And so which makes that unique is that probably more than any other field doctor, he was adjusted personally by Gonstead probably more than anybody else, which he saw Gonstead do a lot of things and that he never taught. He knows exactly, the way Gonstead palpated, adjusted, what it felt like, all that. And so Dr. Landers, he practiced like almost 45 years. And he was just a real detail-oriented individual. And he palpated more than any other doctor I've ever met. I've never met a doctor that palpated like Dr. Landers. And, that kind of goes back to when Gonstead had a tough patient. They always said that he would put down the scope and go back to his palpation, because that's really what makes us good is our exam. And at the heart of our exam is the palpation. So, a little bit on a housekeeping note, guys. With all the social media buzz about Gonstead, there's really never been a better time for Gonstead than right now, because people are really learning about it and people are seeking out doctors, and we're making a lot of referrals to doctors all across the country. But sadly, it turns out there's a lot of people doing, out there in the name of Gonstead, doing very, very poor work. And the problem with this, guys, is, Gonstead is really the last bastion of true chiropractic left. And if we allow the good name of Gonstead to be ruined, then basically all we're going to have left is our individual reputations, because our profession's reputation is pretty much in the toilet to begin with. So we really need to, take it upon ourselves, guys, to keep our house clean, to hold ourselves to a high standard of what we call Gonstead. And what we're finding is a lot of people just aren't doing a good exam. They're not palpating little at all, maybe just palpating where they find scope reading. So I'm going to really, challenge you guys, throughout your guys' careers to hold yourself to a high standard, to honor the man, honor the work, so that we can do what's best for our profession and our patients. So do a good exam, and we'll talk about that tonight. So we're going to talk about chronic subluxations, or the chronic patient. So if you look in front of you on the screen here, this was the lady that I said won my worst spine of my career award. And this x-ray epitomizes everything about what is chronic. This lady has not a disc in her back. She came in, she's extremely old. I forgot exactly how old she is. Can barely walk, not a disc left, extreme scoliosis. If you look on her lateral, I mean, it's just wicked. It's wondered how this lady even walks, and she got amazing results. So, but she's a challenge, because when you look at that x-ray and then when you check her, I'll tell you right now, you got to go, you almost scratch your head going, where do I start with this lady? And the answer to that is, by looking at the x-ray, you just don't know, because everything's wrong with her, everything. There's not a section of her spine that doesn't have a problem in it. But that doesn't mean you do everything. You don't adjust everything. As Gonstead practitioners, we have to find the cause, the subluxation, and correct it as specifically as we can. So how do we begin with this patient? And like I always tell everybody, you follow your exam. You adjust what your exam tells you to adjust. And that's at the core of everything we do. And what we're going to talk about tonight specifically is, how to do an exam specifically to make sure we don't miss these chronic subluxations, because this lady's all chronic. But what you'll find out a lot of times in practice is you get a case in, and you'll start off with a patient, and they might get some initial results, but then they stop. And it's like, what am I missing here? And a lot of times it's the chronic subluxation or the subluxation that's been there a long time. So, just out of curiosity, how old does a patient have to be to have a chronic subluxation? Any ideas? Basically at any age. For the most part, chronic subluxation just means a subluxation that's been there for a while. I need to try to get the screen. Marcus, how do I get the?
What are you trying to do? Come back to
I'm
us.
trying to get back to where you guys don't see that anymore.
Okay, you can
I
just
just want you to see me in my camera now, so I'm gonna go back to.
stop presenting that. Yep, perfect.
Good. All right.
Perfect.
All right. So when we get into this, you know, so just assume everybody's going to have something chronic. So I'm not talking about chronic symptoms. I'm talking, you know, because you can have a chronic patient or chronic subluxations that present as an acute case. Somebody comes in, can't walk, they're crooked as all ever. That may still be, you know, a patient with lots of chronic issues. So what we're going to talk about is how we find those things, because a lot of times we're overlooking it. And you know, we first just have to go back to, well, how do chronics begin? So let's take Mr. Chronic here. So I brought my spine models in, and this is a lot of times what you're going to see in a patient. Let's see if I can hold this out without things falling apart. You know, you got Mr. Bad Disc down here, it's gone. You know, a little bit thinner here, you know, a little bit more disc here, and as we go up, then way at the very top, we have a nice, you know, healthy looking disc. All right, and this is extremely common that we find in people, and we know how this occurs, right? So what happens when we get a subluxation, right? The disc becomes damaged, correct? And what happens when the disc became damaged, the bone moves and gets stuck. So we have lack of motion. And it's a lack of motion that's the problem. That's why we push on people. We're trying to restore motion and function, because this process can stop. And we're the only ones that stop it, because when motion's restored, you know, the body stops trying to get rid of the joint. Your body's incredibly intuitive. If you understand that principle, you know, you can kind of work out how a lot of these things come to be in a lot of patient symptoms. So when it comes to spinal degeneration, you just think about it. You know, if you take motion out of any joint in the body will get rid of that joint. They did some really cool experiments with rabbits where they, you know, they took the long joints and they put them in a cast, and within a period of a month or two, you know, that joint would fuse into a solid bone. And then they would also take the rabbits and they would snap like their femurs, and they would introduce constant motion in that fracture, and a joint would form. So, you know, the body's going to either give or take away depending on what it needs based upon movement. So long story short, no movement in a joint, the body's going to get rid of it. Too much motion or enough motion, it'll maintain it. That's why when we look at x-rays and we see, you know, things like this, you know, we know that, you know, this is a joint that's been stuck for 30 years. It takes roughly about 30 years to get to bone on bone and on the average case. And so when we look at x-rays, we can kind of age, you know, how old the problem is just by saying, hey, where are you at in the spectrum? You know, what phase are you in? And once we restore motion and function to that, you know, that process will slow down or stop to a large degree. And that's what's nice about what we do. It won't grow back. You know, people say that grows back. I think they're lying to you. Now, this disc can swell. That's what people don't realize. You know, this disc, even though it's thin, still has a capacity to swell some points. So sometimes you'll see a swollen D5 disc that looks a little thicker, but I've never seen them grow back. You know, I've heard people make claims of that, but I've personally never seen it. So just know that when we see this just means it's old, guys. And that's all a chronic subluxation is old. But the problem in the rub comes in is these suckers can be hard to find. Okay, so that's what we're going to talk about. So what happens from the get-go on these things? Let's understand that when you have a normal healthy disc, okay, you know, the nerve is healthy. The nerve can do everything it wants to do maximally. And typically when we get an acute subluxation, you know, we're going to get the misalignments and we're going to get the nerve pressure, okay? And we use our scope to determine, you know, where there's a nerve reading. And what's a scope looking for? It's basically looking for heat, right? Now it's picking up heat from two different sources. One is the direct thermal heat from the vasodilation or vasoconstriction on top of that nerve, because that vasodilation stuff's going to occur right on top of where that nerve is, okay? So we're going to get that, and usually it's asymmetric, especially more so in the acute cases. But it can be bilateral, okay? There can be equal amount of vasodilation or vasoconstriction on top of that nerve. But especially when things start getting chronic, you know, as things get chronic, basically the body starts turning the volume down on a lot of things. So as this thins, you know, you kind of, you know, the nerves start getting affected more bilaterally. So you're going to find a lot more bilateral pressures in the extremely chronic cases, or at least I always have. Because when I started doing the exam, we talk about how to do the exam. You know, you'll find a spot with your hands that you didn't initially find with the scope. And then you go back and tilt the scope and do the things we'll talk about. And you'll be like, oh yeah, it was there. It's just because as things kind of degenerate and squeeze down, you know, a lot of the symptoms that you're finding with your exam just kind of, they all homogenize. It's all bad now. Like that lady that I showed, you run your hands down her spine, it all feels bad. Because it's all been bad for decades, probably longer than I've been alive. So, you know, it's one of those things you have to be able to now say, are there additional tools, or what part of our exam do we need to pay more attention to really figure out what's going on? But when you get that acute subluxation, you know, the body's just going to cause spasms. The biomechanics of the disc gets screwed up, so there's no motion. So that lack of motion is what precipitates the degeneration. The body just keeps whittling away at it till it's gone, and the nerve starts getting affected in different ways. You know, nerves do a whole lot more than cause pain, and we all know that. That's why, as Gonstead doctors, we see a lot more than just back pain cases. We see a lot of visceral cases. But we got to know that a nerve, you know, always controls motor units to wherever it goes, and that's key. So the tissue on top of that nerve is going to be affected, and if you know what to look for, it can cue you in to, you know, what you should, you know, be looking for, and maybe there's something going on there. So let's talk about the exam. All right. And you know, what makes us great is that we're the only profession, or only people in this profession, that do a consistent exam. You know, we use 5 criteria to determine what to adjust. And, you know, if we follow it right, it tells you what to find. But, you know, it's not as easy as it looks sometimes. And some things are not as clear. You know, there's still cases I'm like, man, this is challenging. You know, it's like, where is this subluxation at? But when Dr. Landers, you know, he was huge, and he was huge on the chronic cases, and he was always talking about scar tissue. And because this wasn't something that I really heard a lot about at the seminars. And when he started training me, he would always talk about scar tissue and tissue changes over time. And this is basically, you know, information he came up with observation for 40 plus years of practice. And it was just, when you start getting your mind wrapped around when something's stuck, or when you get a subluxation, this nerve is going to cause muscles that it controls to go into spasm. That doesn't mean that spasm's painful at the time. All right. So what happens is when this nerve gets pinched, the muscles it controls go into spasm at some level. So there's increased tone. Well, essentially, until that's corrected, that never really changes a lot. That's why you may notice, like, a lot of tennis elbow cases and stuff, they can rest their elbows till doomsday and it never gets better. Why? Because the nerve's still being pinched, causing the muscles in the forearm to be in spasm, so they're truly never getting rest. But what happens to any muscle when it's contracted for a long period of time and not allowed to rest, it gets damaged. So over time, it'll become fibrotic and actually infiltrate with scar tissue. That's the whole fibromyalgia. It's, you know, that's what they're finding, is that there's actually fibrotic changes within the muscles. Well, what that does over time is you take a muscle that's been in spasm, and if you guys know what muscle spasm feels like, you know, you guys know that I talk about some additional muscle palpation that Dr. Landers had figured out. But so muscle, you know, any muscle, even on a bodybuilder, at rest should be soft. Okay, it should not be hard. It should not be ropey. It should be soft and supple. Only if it's contracted or in spasm should it be firm. Well, the muscle's in spasm for years, it gets fibrotic. So even if you correct, you know, a subluxation that relaxes that muscle, scar tissue can still make it feel quite firm and hard, almost like it was in spasm. And then that's a lot of what causes people to have a slow progress over time, is because, you know, if a muscle's pulling like this for 40 years, it's all scarred up in this position. So now you've relaxed it, it can go like this a little bit, but it's not, it still can't, you know, give you all it wants to give as far as what it should range of motion wise. So that scar tissue over time through, you know, just normal use will slowly be absorbed. And, you know, Dr. Landers, when I took over for him, you know, we did a transition period, and he would show me these cases where, like, you know, on a guy's back, you know, you have a spot of scar tissue about the size of half of a football, and over care, that thing would get smaller and smaller and smaller and condense down until it was gone, just by, you know, the body reabsorbing that scar tissue, working the muscle and remodeling. But, you know, that takes time. But that's one of the reasons why, you know, you'll get some results in people, and it takes a long time for them to get fully better, is because the body's got to rework all that tissue. You know, it can take a year for the body really to rework everything that's going to be reworked, but it'll never ever get to that point if we don't correct those subluxations. And like I said, it all gets back to, those are the ones that typically elude us, and that's why, you know, if Gonstead had a challenging case, he would go back to palpation, because that's basically one of the main ways we're going to figure these things out. But The x-ray can kind of clue you in. So let me show you a picture here. So when you're doing your exam, right, this is Mr. Chronic. All right, can everybody see that pretty good? All right, so when you're scoping, let's say that, you know, we're going down, what I see a lot on my chronic cases is that, you know, when you get an old one like this, and then a not so old one above it, and let's say, you know, the patient comes in with neck pain, what have you. You do your exam, you're going to find a big old reading right here on this newer subluxation. But a lot of times we're preoccupied because this was such a big reading, we actually missed the small reading down here. Because sometimes, you know, what Dr. Landers used to tell me is that, you know, the body over time kind of turns the volume down on all the findings of subluxation. They're still there, but they're minimized because everything's kind of homogenized. The nerves have become weaker. The autonomic response is not as grand, so you're not getting as much vasodilation, you know, differences. All the tissue can be edematous or fibrotic feeling. You know, that real acute boggy feeling, you know, that kind of, it'll always be there to some degree, and sometimes you've got to start eliciting it. And we'll talk about how Dr. Landers and Dr. Gonstead would palpate to kind of wake that up, is what he called it. He called waking up the tissue. But you know, when you feel the patient's spine looking for that paraspinal edema, you know, even though it's there, it can be very, very hard to find because everything feels like that. Like on that lady, I mean, it all feels, I mean, that tissue just feels, you know, what I know in my mind, because I've developed the sense for it, is just all scarred up. It's just all kind of chronic tissue. Whereas, you know, not, you know, it's just like when you guys know how to palpate, because normal tissue feels one way, chronic tissue feels another way. And when you make that connection and start feeling for that, that's when it'll kind of help you out in there. But on Mr. Chronic, so what we do is when we do our initial exam, most of us will just scope, you know, going straight down with our probes. And that works most of the time because the nerve pressure is asymmetric. So on Mr. Chronic here, you have a nerve pressure here, and the little bulb is where the majority, so it's asymmetric here. So as we run it down, we're gonna, let's say this is the more acute subluxation in blue, and this is the more chronic one in red. This is what I see a lot, is as we run our scope down, we're gonna find the more acute subluxation above and see this nice big break here. And we kind of fixate on that. And as we kind of scope down, we'll miss this little one right there. Okay? Because you're gonna see this a lot, because when you get a subluxation, right, that doesn't move, well, the one above and below has to start working harder, you know, to make up for that loss of motion. So that increase in biomechanical stress, all right, over time is going to cause it to be damaged. You know, Dr. Gonstead talked about the subluxation within a compensation, you know, especially in the neck, you know, the ones that are flexed, typically one that's open in the back we never touch. Well, left along and compensating long enough, some of those will become damaged, and they'll be stuck in the flex position, and they'll start degenerating. So really, you know, when it's open in the back and large disc, you don't touch it typically, because that usually means that's hypermobile. You know, obviously your palpation's got to verify that. But when you see those flex segments that are open in the back on a thin disc, well, that means that was compensating for so long, it became damaged, and then now it's degenerating because it's subluxated as well. But when you see these, you know, just think about it. When this thing moved, your body's going to try to give you the full range of motion that it can. And it does that by making these work harder. So over time, then guess what? This one sustains damage, starts to damage. That's why you get that stacking appearance. You know, look like this. Oh, this one's, and you saw that one's older, than it's spread to this and this. It's not like it spreads like a disease. It's because the biomechanical stresses were there, and they all got damaged at some point because nothing ever got fixed. And when we look at the X-ray, you know, that's going to clue you in. You know, when my new patient procedure, you know, we do the consultation, and then we take them to X-ray, and I throw the X-rays up, and then I do my exam. And you know, what I want to look for is, I want to look for these bad looking discs or any degree of, you know, degeneration. And because it's not that I'm just going to go there, it's going to make sure I don't miss it. So when we do these exams, okay, and we see there's a big one like this, and let's say we're looking at the neck, and this one here is a nice normal looking D1 or D2 disc, but then down here below it, I see a D5 disc. All right. Well, what that's going to do, it's going to cue me into, hey, when I get into that area, I better scope a little slower. I probably should do a tilted glide, because you guys know the procedure for bilateral pressures is to camber the scope, tilt it a bit, so that one probe's coming into over that nerve before the other one. So what'll happen is that is that, if you don't tilt the scope, see down here, let's say this one's a bilateral pressure. If you don't tilt the scope, you'll get these, unilateral pressures or asymmetric heat swing, pressures. But when they're bilateral, you'll get no reading at all. So you'll just go down and think that there's no pressure there. But if you tilt the scope and go over it, as one probe comes in first, you'll get the swing. And that's what we've been finding. A lot of people, they're just scoping and they're only checking and palpating where they find scope readings. So if you're not palpating the entire spine every time, you're going to miss these. So that's why it's imperative that, regardless of what you see on the scope, you got to static palpate, palpate the whole spine. Because when I find a lot of times, I'll do my scope first and then I'll run my hands down the entire spine checking it. I'll find a real swollen spot. Then I'll go back with my scope and scope slower or tilt it again, and I'll find the reading that I missed, because you won't pick that up if you don't tilt the scope at all. So at a minimum, it's probably a good habit to get into doing a tilted pass, or at least making sure you're going over with your hands and then going back and verifying that there's a reading there, because you'll miss a lot of them like that. Okay, so understanding that concept that just because you don't find a nerve reading doesn't mean there's not a subluxation there. Just means you might have missed a nerve reading. To find these cases, if you want to get the results that nobody else does, you got to do what nobody else does. You got to check better than somebody else. And most people just aren't checking enough sometimes to find some of these cases. And it's just usually a lack of palpation or maybe an understanding of what they should be looking for. But when you get your X-ray and you see that there's a D5 disc somewhere, you better make sure you take a little bit extra time and palpate that segment really good and scope it a little bit differently to make sure you're not missing something there. Because I can almost guarantee you that if you see one of these, there's probably a more acute subluxation in the vicinity somewhere that you're gonna find. And that's probably what you'll start with, because the squeaky wheel gets the grease. But that's the patient, like I said, the first adjustment, they'll think you're wonderful. Yeah, I felt so much better after adjustment, but then adjustment 4 or 5, they stop getting results, and you're still finding this more acute thing, or maybe you cleared it out, but you're still they're still hurting, or they're not fully well. It's because you haven't addressed the other ones. So I'm not saying every time you see a degenerated disc, go and whack on it. No, your exam will tell you when it's time. You have to listen to the exam, and you only adjust it when it's time to adjust it. But if you don't find it at all, because a lot of times people see it on the X-ray, but they just don't pay any attention to it because it didn't show up on my exam. Well, it was probably there. It just you didn't find it. So when we go back to the chronic nerve, when this nerve gets really chronic, muscles are dependent on nerve firing, right? So what happens to a muscle that doesn't get firing into it? It atrophies. So if I cut the nerve to my bicep will just wither away. Okay, and this was what happens in hernias. When we were training with Dr. Landers, my buddy Chris Waddell, he would come down and train with me, and he developed a transabdominal hernia. We called it his goozle. So it looked like he would bear down and like an egg would pop out of his lower abdomen. And Dr. Landers was checking, and the nerve trace around was coming from like T11. And he started working with it, and we watched that sucker just go away. Because what happens before it tears, if you can catch them before they tear, you can fix hernias like that. Because what happens is that nerve's getting weak, and that abdominal muscle is just thinning out. It's going to get thinner and thinner, and at some point it'll tear. And that's when you got to get a repair. But if you can catch it before that, those will fill back in. So if we know that tissue and muscle atrophies or changes due to lack of nerve firing, you can just visualize a person's back and kind of already see where there's going to be some chronic subluxations. And the easiest place to see this is going to be around the thoracolumbar junction, because it's inherently one of the most weak spots in our spine, just because the thoracics have the ribs and there's very little rotational movement there. And then you hit the lumbar, so that junction between the two is just an extremely high stress point. So what you'll see in a lot of people is that, especially if they got a little bit of extra weight on them, you'll see kind of their fat kind of hangs and folds that kind of come down around to the sides. All right. Well, that's not just because there's extra weight there, guys. That's actually because that muscle's atrophied under there. You can see it in people who are lean as well. And the way we palpate this is that there's a lot of old-timey techniques that the guys, older generation did that we've kind of gotten away from, but they're extremely valuable. And one of them is nerve tracing. And what's funny about chronic subluxations is that, the further you get away from the spine, the more information you sometimes you can get about them. It'd be nice if we had a scope that would scope this wide, but we don't. But with your hands, you can pick up a lot of information. So if you will start doing the same type of static palpation that you do on the spine, but out laterally, and run your hands down laterally, get a couple, 2-3 inches away from the spine, and you can even do it all the way around the side in this area. You're going to find where that hand dips into that atrophied, we call deactivated tissue. And these are just terms that Dr. Landers uses, so that's why I use active, not active. But so in addition to your normal static palpation that we do, you want to add in going a little bit more lateral. And just as you're learning this or practicing it, just start off, an inch out and then go 2 inches out and see if you can find it. Or I recommend finding a subluxation and see if you can just go out lateral to it where the nerve goes out and see if you can pick up tissue changes and learn to identify that, build that mental neurocapacity to start identifying different changes. And what you'll realize is that, you're like, hey, it's going to make as much sense to you as the paraspinal edema does. And what's nice about it is it can work in reverse. So how many patients come into us and, doc, I got a pain right here. Okay. Well, I say, touch it. And they'll touch it, and then I'll find it, and you'll trace that nerve all the way back to where it comes out in the spine. If we know where nerves go, everybody should know their anatomy. You can figure a lot of these things out, like groin pain. Groin pain, most of the time that I find groin pain, that's like a T11, T12. Because if you look at Mr. Chronic again, okay, nerves don't go out straight lateral. Especially in the thoracic lumbar, that nerve travels down at an angle like this and wraps all the way around. And by the time it terminates in the front, that sucker's in the groin. All right. Sure, you can have a bad ilium that can cause groin pain as well, but the lion's share of the groin pains that I find usually come from that area there. And it's just because that's where the nerve goes. They're getting muscle spasm right into that groin. But you have to understand that you just got to understand your anatomy. But if you go down there, and obviously I don't recommend palpating everybody's groins and going all the way back up, but if you could, you would find that you would trace extremely right back to where that nerve exits the spine. I mean, you can do that with shingles patients, all sorts of things. But the green books go into that extensively. I forgot which one it is, but those old timers, if you had toe pain, you'd see them, they'd mark and they'd trace it all the way back up to the spine. So but it's just a great tool. So get in the habit of looking for that. And when God said palpated, there's all different schools of thought on palpation, guys. And and nobody's right, nobody's wrong. I'll just tell you what Dr. Landers said God said. And because some people are like, oh, it's all light palpation. Some people know it's all deep. Well, my personal opinion and what I was taught and what I was told God said, it was you do it all. And there's each one's going to give you a certain amount of information, and each one has its shortcomings. Our receptors in our fingers have things for light touch and deep pressure. And tissues, especially when they're chronic, aren't giving you as much information, as an acute one may. So the light touch is very, very valuable. So I always do that first. But if something's really chronic, you actually kind of need to, what Dr. Landers used to call waking up the tissue. And that's when the more you touch a tissue, the more you get a response out of it. Just like, if you scope a patient, if you keep scoping, does that break intensify or go away? It gets worse, right? Right. Because you're waking up the tissue. You stimulate the tissue. So Dr. Landers and Dr. Hansen, you watch them palpate, they would do their fingers this and kind of get under the tissue and do this little jiggle thing. If you watch the palpation when on Gonzalez's videos, he get into this, there's a slight jiggle, and Dr. Landers did that a lot. And he would get on all different aspects of that spinous. When you're palpating a spinous, challenge, get up underneath all different aspects of that tissue and challenge it in different ways. You'll get different responses. When people try to palpate me sometimes, if they just palpate straight on the spinous, I can't even tell they're on there. But you get on one aspect of that, spinous, it might send me right off the chair. And that's what you'll find with your patients too. They're like, doc, I don't feel you touching me. But that's a bad segment because it feels bad. But if you get on it maybe from the top to bottom or bottom to top or left to right, one of those is going to elicit more tenderness than the other part. And a lot of times it's when you're increasing the listing, you'll get a little bit more symptomatology out of it. So you have to get in there and kind of really wake that tissue up if you're really trying to figure out, and which means you got to spend some time palpating these people. As much as we want to be efficient and see people fast, sometimes it takes a little bit more work to kind of work out that tissue. So as far as the static goes, you got to go in there and really kind of get under the tissue, wiggle it, and go over it multiple times. And the differences, guys, can be very, very subtle. And that's the art of what we do with our palpation. The old timers like, Dr. Denny and these guys, they can just barely touch you and feel the difference in tissue. That only comes with time and a lot of practice, a lot of repetition, guys. Your brain has to develop the differences, and that's why we have to do it over and over. But you check the segments, and then so when you're starting out, what was helpful for me, ask for feedback from the patient. When you find an area that's in question and you get on that segment and you just say, hey, because there's going to maybe 2, 3, or even 4 that to you feel the same. And yes, we were always told, if all being the same, what do you go? Lowest, most tender, correct? So that's what we're told to do. But if you want to build your mind to be able to identify these ones that actually are the worst without having to ask, you got to start off by asking, say, hey, I'm going to push on these 2 or 3. Which one's the sharpest or the most intense to you? Or, they're like, none of them hurt, because they're all, the pain sensation is just not there for the patient. So which one do you feel me pushing on the most? Doesn't matter, whatever you say. So you get on all of those, and whichever one's the most tender to that patient, then go back and palpate again and see if you can perceive a conceptual difference in what they feel like. If you do that repetitively, that's how you're going to build that mental Rolodex up to go, hey, this is what a chronic one or a more tender one feels like. And you just do that over and over. When you get to 10,000 repetitions, you'll be pretty good at it. So that's what all those guys did. They would just palpate over, and they would say, sometimes ask which ones felt like that, and they just knew. So start off doing that for sure. And once you get your static palpation down, then we go into the motion. And motion is difficult because I think a lot of people forget that we're not looking for it doesn't feel stuck, because it may all feel stuck, but does it feel stuck compared to the segment that we're referencing to, like the one below it or one above it, whatever you want to check it with. So let's say you're motion palpating the low back and you're rocking them back and forth. It may all not feel like it moves good, but as you go through each segment, you'll find one that stands out as more stuck. And that's what we're looking for. It's just a difference, guys. So it's not that when you first start, you're like, it all feels stuck, I'm confused. Well, just slow down, check again. Which one feels more stuck? And then that's the one you kind of want to hone in on. Does it have the most swelling? Does it have the most tenderness? Is there a scope reading there? When you put all that together, and what does it look like on the film? And then you go, hey, yeah, that's the one I'm going to be adjusting today. Right? But you got to get to that point, because then, the one thing the standard Gonstead exam is good at is finding the acute subluxation. And that's half the battle in a lot of cases, because, the scope rating's nice and big, the swelling's pretty significant, it's pretty easy. But, you guys know, if you've followed any patients through care, it gets harder and harder to figure out what to adjust, because all those findings are going away because the person's healing. So, if you're doing your job, where what used to be real swollen shouldn't be as swollen. If it should get less and less and less, and eventually feel like normal tissue. And that's how I judge progress and care in my clinic. I don't go by the symptoms. Yes, I want them to be feeling better, but I know I can tell them, and this is a practice management thing too, guys. If you have mechanisms to show progress or explain progress to a patient, even if they're not feeling better, you can get them to give you time, because that's, with chronic people, that's the big deal. Like this lady, here, and I actually had an old guy start with me last week. He's got a horrible spine like that, and he's got just so many problems, but he's only hurting in his low back. And I told him, and I pointed out all the damage he's got in his neck, or whatever. And I said, hey, man, because he's like 90. Anyway, I said, you have all this, but it's not hurting. I said, I'm not going to touch that unless it starts bothering me, because quite frankly, neither you or I are going to live long enough to figure all that out. Because that's the truth. Just, it's real honest. If we start stirring up stuff that's been not problematic, the odds are, number one, you'll make him hurt and he'll leave, because, there's no way that spine is going to change without some ups and downs. So, case management, practice management type of stuff. If somebody comes in with low back pain and nothing else, and despite what they got, and they're really old or whatever, probably best not to touch it until it demands, that you touch it. Because, chronic subluxations, especially like that lady that I showed the x-rays with, I mean, she's got so many problems, and I haven't really worked on it much with her. Like, I didn't touch her neck for a long time, but eventually her neck did start getting sore. And because I warned her about it, I said, you know, I'm not going to touch this right now because it's not bothering you. But I said, odds are it's going to. And that's what you guys have to understand about the chronic subluxation that also will stagnate your results. So when we start working with people, all right, and you can be 100% correct that fifth lumbar is the subluxation, and you can give it a great adjustment, okay? But the whole spine has to change from this, okay? When I make one adjustment, even if it's down low, that's going to change the patient all the way up to the eyeballs, okay? Everything has to adapt and work better to achieve balance and, you know, homeostasis, what have you, okay? If there are other subluxations anywhere around that, they have the potential to kind of say, halt, no, we're not going to do this. We can't adapt and achieve balance this way. So one of two things can happen. Most commonly, if you're correcting things, as those changes go through there and get stuck at these other levels, they'll start to get swollen and tender, eventually symptomatic. And that's why you'll start finding them on your exam. If you're doing your exam every time, you'll keep up with those changes if you're seeing them frequently. But what can also happen is that if this and things go, oh, we can't change, sometimes this has to go back into the type of pattern it was. So it won't stay fixed. You'll be like, I'm adjusting it good, but the patient's not getting better in this, you know, because you're not addressing other issues that may be preventing it. Okay. Because, you know, these other chronic areas. So let's say you got a nice one like here, and like this is L5, and let's say this is T12, and it's doing whatever it's doing up here. You know, he's only there, only got low back pain. You're letting all these other things lie because they're not problematic. But if you check them clinically, they are bad. So the way I do it in my practice, you know, and that's why we take the full spine x-rays, guys. You know, Gonson was real good about looking at a film and knowing, hey, you know, what was going to cause a problem and what was going to come up next. Because when you make a correction, you know, if you got an L5 that's rotated like this and a C2 that's rotated like this, as I spin L5 around, that increases C2's rotation. You think that some point C2 is going to get aggravated or cranky on you? Absolutely. And that's what he would do. He said, hey, I'm going to start working on your low back, but pretty soon your neck's going to start to hurt. And they just thought he was psychic, you know, because he's like, what type of voodoo is this? No, he just understood how the spine works. And you can do the same thing. Just like when people throw up films, you know, we can't tell what's subluxated on a person for sure. But if you understand these concepts, you know, you go, well, if this is doing this, then, you know, this is going to, you know, this will calm this down, this will calm this down, but this is still not compensating. You look where I always tell when I teach x-ray in my program, I always tell the students, look where it goes from normal to abnormal on the lateral. So if you see a nice lumbar curve, and then from T12 it goes straight on the lateral, well, you better be looking where that thing stops and goes straight, because where curves go from normal to abnormal, something bad has to happen. Okay, and like I said, it may not be symptomatic per se, but structurally something bad's happening where nothing can compensate. Because if the body's going to compensate, you know, it's going to try to give you those curves and it's going to keep you balanced. So like if you see an x-ray on somebody and you position them the way, and like their eyes never come back to level, you know, let's say they got a bad T3 that throws them off, you know, it's like a bad PRI, but their eyes had never actually come back to level. Well, you know, there's some things that's limiting the neck's ability to compensate, because typically, especially in the upper cervical, things are going to compensate and bring the eyes back to level. It's the riding reflex. It's the most powerful, you know, thing we have as far as, you know, structurally to keep us level is the riding reflex. We want to keep our eyes level with the horizon. And if that can't occur because of subluxation, you know, then what you'll see on x-ray is that, you know, the eyeballs or the skull still won't be level. Okay. And so that just cues you in. Okay, and then you go, well, where's that breakdown? Where's the spine damaged and not allowing this to compensate? So then you just got to hunt that down with your exam. But that's what comes into play when they're chronic, is that you're going to get initial results on a lot of patients because you're adjusting these more acute subluxations, but it's the chronic ones that are going to throw a wrench in all your plans, and then you just have to ferret them out. But it just goes back to doing a really good exam and being really good at palpation and not cutting any corners. You know, we've run into this a bunch too lately, that with all the buzz, there's some practices, you know, new young practices that are blowing up like fast. here's the problem with that, guys. It takes a lot of practice, a lot of time to become good to where you can do an efficient, good exam in 5 minutes. Okay. My average visit's 5 to 7 minutes, probably more like 5 a lot of times, but I'll give the patient all the time that they need. Right. But you can't a lot of times do that when you're coming out of school. So what's happening is that people start cutting corners. They start rushing, and they start not palpating everything like they should, and that's going to degrade the quality and cause bad things to happen. So the personal standard that I hold myself to is that I say, hey, if I have to cut corners to see the volume that I'm seeing, then I do not deserve to see that volume. Okay. You have to keep yourself humble, guys. If you really want to stand for Gonstead and keep this profession, or keep this name good, because it's all we got, you guys have to hold yourself to these type of standards, and then don't cut corners, because you'll get faster as you get busier. But right now, you guys are just starting practice in the best time, and you guys can get busy a whole lot faster than we ever could, just because we all did it by word of mouth. There was no social media. It was all personal reputation, brick by brick type of thing. Now you guys can have 30 people looking for a Gonstead doctor in your area. That's just the reality of what we live in. So you guys are going to have the potential to be seeing good numbers right away, but you may not be prepared for it. When people ask me, how did I get faster at seeing patients? I saw thousands of ghost patients. When I opened up my Rockwell office, I hang ghost charts. I would hang a chart up, and I would grab it. Imagine there was a patient there and walk through. I would set a timer. I would just do everything I would do, visualizing the patient in front of him, scoping, palpating, walking to the high-low, writing it down, deliver the adjustment, and figured out where I was being efficient and not efficient. And I would just start refining it. And I did thousands upon thousands of that while I was slow, and that's what allowed me to have a good, refined, procedure, getting rid of what I, didn't need, like certain palpations I was doing that I didn't need. So I found out what works, what I could do efficiently. So that's what you have to do, so that you can, devote time to that. But if you don't practice things like that, and you get these chronic patients that may take you an extra time, then that's where you can kind of get backed up and then you go, oh crap, I got 3 people waiting for me. Now I got to cut corners, see? And then that's where you're going to start burning your house down. So it's just not it's just something we all need to watch out for, because it happens to the best of us. I mean, I did it early on in practice too, sometimes, where I'm like, but it's bit me. And I just, every time, I teach you guys, I always tell you, everything that I tell you, I learned the hard way. It's because I lost patience. I did something wrong. So, I just don't want you guys to have all the learning curves that I did. So first of all, at this point, any questions of what we covered so far? Any clarifications?
So when you're getting a bilateral reading and you start tilting the scope, would you see a break to the left and then a break to the right on each probe on that side? Or how would it look when you're tilting it? Would it be both to the same side, or what are we looking for when we tilt it?
Right. So let me draw that out for you. So, well, yeah, on Mr. Chronic, basically, as you come down, so like this one is basically drawn so that if you tilt the scope like that, and it's probably not drawn correct. Yeah, as the one probe comes in, okay. So let's say it's bilateral. So we got a probe here and a probe here. If you tilt it like this, as it comes down, it's going to swing this way, okay. Then this is going to start coming back, and then it's going to swing the opposite way. So it'll actually probably be more like a little bit of a zigzag thing. Okay, so I really didn't draw it too correct. This is just to try to give you the thing that if you tilt this probe, you're going to get a reading. Yeah, but technically it'll be more of a Z shape on it. So you'll see but it's still within the nerve, the nerve channel like that. Does that make more sense?
Yes, that does.
Yeah.
Thank you.
Yeah. But a lot of times, there's still one of those chronic ones and stuff it doesn't matter, because like you can have a bilateral pressure on acute subluxation as well. But yeah, the main thing is you will get the reading if you tilt that, and you won't see anything if you don't. Yeah, good question. Anything else?
Yeah, I have a follow-up question on the bilateral reading with acute versus chronic. Did you see a predisposition to have a bilateral reading on chronic or acute, or is it like 50-50? There's not really that doesn't really matter.
Well, I find a lot less bilateral readings on the acute ones, just because if you think about what happens when the disc gets traumatized for the first time, okay, and we're talking, that's why I think the majority of what we see in practice, they're acute exacerbations of chronic conditions. I would say at least 60% of the time, maybe even more, because you look at it, it's not a D5 disc, but maybe it's a D2 or D3, which means it's been there 5 to 10 years. So it's an acute manifestation of a chronic subluxation. Because anytime the disc starts to tear again, it's not like you damage it once and it's static, it's stuck, and it never undergoes any more damage. No, you continue to tear these fibers, and that's why we get extrusions on people, guys. Is an extrusion happens typically when a disc has been neglected for years, it's been stuck. As it degenerates and more trauma occurs, it eventually just gets tore completely through, and that jelly starts squirting out the back. Okay, but in the acute, brand new type of deal, you're just more likely to have it's just like symptoms. Like, why is the pain on the right side versus the left? You'll have these patients go, well, my shoulder pain started on the right, 2 years ago, but now it's in my left one. It's because, well, and it's complete luck of the draw with the misalignment, which nerve gets irritated more. But typically with an acute disc, because of the way the fibers derange or what have you, you're just going to have a predominance of one side irritated more than the other. So that's why you're like, my right shoulder hurts, but both don't hurt. But over time, then somebody comes in, well, like I had a lady come in, and she originally she said her right shoulder had been frozen a couple years back, and now it's happening into her left. And it's just because what happened is things, she didn't get the proper care, that, as one nerve got bad and caused that frozen shoulder years ago, well, now it's degenerating. And as things, think about it, as things kind of degenerate down, squeezing down, eventually, as this foramina gets smaller, both nerves are more likely to have some type of compromise. And a lot of the compromise comes, guys, is if, we tend to see these models, we think, oh, there's just a nerve. Well, there's always an artery and a vein that go along and actually ride right with it, okay? So a lot of times it's not like you're not hard pinching it, but you're getting congestion, like venous congestion around that nerve, which is as bad as pinching it. If you change circulation to a nerve at any level at the nerve root level, I mean, that's what we're looking for. And so you're just more likely to get unilateral representations or manifestations, really acute thing. But as this degenerates and goes down, then you're just more likely to have bilateral nerve involvement. I mean, I still find a lot of chronic ones just have single-sided breaks. I pick them up, a lot of them, but like I said, there may be 15 to 20%, of the chronic ones that are bilateral, whereas if it's acute, it might be 5%. So, but I find that's a lot of times because, I just know when I do my palpation and my scoping, I miss a lot of breaks when they're chronic subluxations, because if I do this first, without tilting it, I miss a lot. And then when I go back and have it with my palpation, I go, oh, well, I missed something. And I look on the x-ray, I found, well, that was, it was a chronic area. It was a really old subluxation. So over years, I've just noticed that most of the time when I'm missing breaks on my standard exam, it's because it was a chronic area and the pressures end up being bilateral. And when I tilted the scope, I picked it up. So and that's just my personal experience, but I think it probably holds true for most people who have been practicing a while. So it's just one of those things, and it makes sense from a biological standpoint that as things kind of all get bad over time, you're more likely to have more. Both nerves are going to be affected to a higher degree. The tissue's all going to be affected. I mean, it's real easy to find an acute subluxation because it's like you run your hands down, your fingers go boom right there, and it's like everything else feels great. It's like you fall into a pothole. But when it's all chronic, and it all feels like that, and then the more sensitive your hands get, you're going to find the subtle differences. And like I said, you go out lateral, and then you can start picking up more changes laterally easier than you can here in a lot of cases. Then you can trace it back and then go in there and really start digging and go, okay, which one's more tender? Never be afraid to ask for feedback, guys. I mean, I do on a routine basis, just because, there's things that are hard to find, and asking for feedback is a tool. It's a tool that we have, you should be competent enough to be pretty sure, but still, if you're not sure, it's better to ask for a little feedback than to adjust the wrong segment. You know, check your ego at the door. You know, the doctor, I mean, the patient doesn't think ill of you. You know, just like an eye doctor, hey, which one's more blurry, A or B? You know, it's like, you know, he doesn't know that without asking. So ask for a little help. Don't be ashamed to do it. Yeah, very good. Trying to think of what else. That's the majority of that's the majority of what it takes to find these things. There are some additional tools and stuff that Dr. Landers came up with that I've talked about, some that advanced muscle palpation, but we're not going to talk about that. But for the most part, guys, you know, it all goes back to doing the exam the right way, taking the time to look for these subtleties and developing the palpatory skills to find them. So it's just going to come with time for those of you guys who are students or just new out of school. You know, if you guys haven't read the book by Malcolm Gladwell called Outliers, y'all need to do it, because it talks about mastery. You know, he surveyed people of every profession and say, hey, you know, how long did it take, or how did you achieve mastery? And what it came down to is basically when you do 10,000 repetitions of anything, you pretty much achieve mastery at that whatever skill. It's just like when people ask me, how do you get a fast thrust? Well, I said, do 100 dry thrusts, perfect dry thrusts, just like you were doing on a patient every day, both arms. Prone ones too. Because speed comes from neural pathways. It doesn't come from muscle strength. It comes from neural pathways. And so the more you fire those pathways the correct way, eventually the faster that's going to build up, because you're just teaching those fibers to twitch real fast. It's just a neurological thing. So, I said, if you want to be good, you got to put in the work. And God said, that's why there's so few of us guys. Most people don't want to do the work. So, it's just like the exam. A lot of people aren't getting the results they should because they just don't want to put in the time or the effort. Yeah, it takes a little extra. It still doesn't take long. If you get good at it, you can still see somebody in 5 to 7 minutes. And that, and I even post check a lot. I think that was a question on the forum about post checking, but I repalpate. I tell the patient, I don't care what I hear. I said, if it's still stuck after I adjust you, I'm going to set it again. Then if I don't hear anything, if I check you and it's moving, I'm done. So it goes back to palpatory skills. You got to know what you're feeling for, but I think that's the basic post check that most people should do if you want to do post checks at all.
Hey Doc, what do you can you kind of just go through quickly your process of your static palpation after you're done scoping the first time? And if you start as you're going out, are you starting soft and getting harder, or what exactly you're trying to look for in that?
Yeah, I always start soft. Because you're going to pick up the softness, especially as you develop the skills. Your hands get really good about picking up subtle changes in tissue. So just start at the top of the head and just do several passes on each segment, each section, and just I don't want to say quiet your mind, but just really try to feel if you can perceive any subtle differences. Because the neck is a lot harder to find the swelling than the mid back is. Almost everybody can find swelling in the mid back, pretty easy. The neck gets a lot more challenging because everything's kind of compact. And then when you get into babies, it's even more challenging. So you just have to kind of run your hands down and just, and you almost have to trust your instinct, because it's almost like you're not sure there was something there, but you go, oh, there's something there. That's how subtle it can be sometimes. You run your hands down and go, oh, there's a difference there, but you're like, is there? Oh yeah, there's something there. And then you can go in and do your deeper palpation and figure out if you're right or not. But when you run your hands down, even if you don't really think there's a whole lot there, just trust your subtle instinct that, hey, there was a subtle change there. This is like adjusting. When I teach you guys how to adjust chair, your chair is not going to become consistent until you learn to feel under your finger where that bone's in the sweet spot. And it's just a feel thing. Once you make that mental connection that you can just set up and under your hand, you can tell that bone's there by the resistance it's giving you, the pressure under your finger. You're never going to be consistent in the chair, because it's not about going through any steps. It's about just walking up, getting that bone where it needs to be, and then thrusting. Same thing with palpation. You got to learn to just be, to trust your instincts and your palpation to go, oh, that's it. But that mental Rolodex doesn't build up till you do thousands of times. All right, so I'll go down all the way the spine, real light, even on the SI joints, palpate both SI joints, top and bottom. Because sometimes like the top will be swollen, maybe the bottom is, or vice versa. And go down all the way through the sacrum. All right. So after I've done that, then I'm gonna pick up on the areas, and then I'll go back into those areas and start doing a little bit deeper, waking up the tissue. Because Dr. Langer said that Gonset said you should palpate hard enough so that both you and the patient know you're on the right one. Because from a psychological standpoint, I think that makes a lot of sense. Because managing people, guys, is a lot more than just telling them, hey, you're the doctor, sit down and let me do my job. In my experience, patients, they want to know that because I've had amazing Gonset guys palpate me to where when they are done, I'm like, there's no way he knows what he's doing. Because I'm like, but he found it, but because he can. But you guys, in that psychology of the patient lecture that I gave you guys, it's not about what the doctor thinks. If to manage people, you got to think about how the patient's perceiving what you're doing. So you can take the best guy who can palpate you without even moving your head hardly, but find the right one. But in the patient's mind, he's going to make question that doctor. And he's probably going to question that doctor that he actually knows what he's doing until he gets better. It's just like, well, I got better, so he must know what he's doing. But on that visit, he's probably raised doubt in that patient's mind. Okay, to some point. At least he would in mine, because it did in mine. And I know the doctor, and I know him by reputation, and his reputation is well earned. But from a standpoint of receiving the care, I was like, how is he getting any information? And I know how he does it because he's been in practice 40 plus years. He's on a whole nother level than I am. He can do things I can't do. But from a consumer perspective, we have to it's like if somebody comes to me with extremities, you guys know that I'm not a big extremity guy. I see lots of extremity cases. I just don't adjust a lot of extremities because I find that the vast majority get better when you correct the correct spinal issue. Because most extremities are hurting simply because they're not being supported or stabilized right. And but I always touch the joint. Like I've showed you how when somebody comes with knee pain, how I should explain to them, and I'll check behind their knee. I'll find the muscle spasms. I'll find the insertion of the knee stabilizers on the medial tibia. And when that's all tender, they about jump out of the chair, I just slap them on the knee and say, that's from your back. And I never have to touch the knee again. But if I don't address the problem that they came in for, they think you don't care. They think you're not listening. And you're a good chance you're probably going to leave them if they don't feel better, like in 2 visits. But if you give them a rationale for why they're hurting in the knee, yet you're only going to adjust the spine, they'll give you time to prove you're right. And that's with chronic people. Chronic cases, guys, I wish we could get everybody better in 4 or 5 visits. That is just not reality, okay? And, there's a limitation of matter and things taking time to heal. So with the chronic patient, half the battle is getting them to give you time. And what Dr. Landers would always talk about was, tissue changes and like, even if a person hurts, like let's say you adjust somebody, I learned early on in practice, you better tell people the potential that as the spine's changing, if something else is too damaged or too stuck to change, it can get swollen, tender, and hurt. Because if not, when you start adjusting people, if they start hurting in other places, they're just going to think you're making them worse or you're hurting them. And they might not even give you a chance to explain. That happened to me a lot. And so that's why I always do that, because I had a lady that came in, told the story. She came in for shoulder pain, I adjusted T2. The next visit, she's like, I almost wasn't going to come back today because after you adjusted me, my TMJ went into acute spasm. It hasn't hurt like this in years. And I'm like, oh, okay. Well, I checked her. Well, after I adjusted T2, she had a bad atlas. Her atlas was really active. I adjusted her atlas, and then she came back the next time. She said, oh, Dr. Waller, my jaw hasn't felt this good in years. And I didn't even touch her jaw. But because I had a patient one time, I still remember, I would adjust her like T12. And while she was still on the table, she'd start going, oh, my neck is hurting, because they changed that fast. And I have to go up there and work on that because I found it on the exam, but I have to go work on that. So I started low and then went high. Just from adjusting that while she's still on the table, the changes would cause this one to start hurting her. But a lot of times it doesn't happen that quick, but it'll happen when they get home. They're like, yeah, after you adjusted me, I got real sore. I'm like, where? Oh, and so let's say I adjusted an L5. Where'd you get sore at? Oh, my mid back. Then I'm like, okay. So I'll go in and I'll find it. So and this is patient management, you prep people for that day one. Say, hey, if I adjust you, okay, the whole spine's going to change. I'll lift your eyeballs. Some other things that may be damaged, stuck, may start hurting. That's okay. That's normal. I'll work on the next visit. Just put ice on it until I see you again. So I don't care how bad they hurt. I've never had a patient not come back because they're like something hurt afterwards, because they understand that that's a process, and I gave them a rationale for it. So with these chronic patients, the way you get them to give you time is you talk about the tissue and the chronic nature of it, and the changes you're looking for. So when somebody coming in, let's say it's visit 5 and there's still symptoms haven't changed at all, but I see a reduction in the swelling, I'll say, hey, Bill, I said, well, the good news is clinically, I said, your swellings are a little better already. I said, which means it's healing. So it's only a matter of time before the symptoms follow suit. Right. So you gave them a rationale, and they're like, as long as the patient has hope, they're typically going to stick with it to a point. But be honest with them. If you're seeing all this improvement and stuff, and they're not responding, at some point you have to go, well, am I missing something, or why is this patient still hurting? But in general, you're going to see clinical improvement before the symptoms are all gone. I mean, the best you're going to hope for is that they go, hey, yeah, I'm already noticing some positive symptomatic changes. But as long as you're seeing the clinical changes, that gives you the confidence as a doctor to go, hey, we're on the right track. And then if you're doing the exam properly, you're going to find these other areas that are going to pop up before they cause too much problems. So if you're just like if somebody comes in low back pain, you're only checking the low back and scoping the low back, then yeah, their neck might hurt because you never knew it was getting bad. So when I see all these other areas, like let's say they've only got low back pain, but they've got a bad C7, a bad T12, what have you. After I'll check them, I do some muscle stuff to check to see how bad the spasm is associated with that area, or the tenderness of the spinous. And then what I'll do is, after you adjust that L5, if what you do structurally helps the rest of the spine, sensitivity on spinuses on other subluxations will actually decrease, and muscle spasms will decrease. I mean, if you get in the habit of checking muscle spasms like in the neck and stuff like that, like, SCMs, and just feeling the tone of it, and you start low and then check up there, what you'll realize, especially like when you do get up to the mid back and adjust something there, when you get back into the chair, a lot of this is already reduced, which means biomechanically you help that area. You didn't correct the subluxation you found in that area, but you took stress off of it so that it's not as bad. So which tells me I don't really I'm not hard pressed to work on that area at that visit. But if the opposite happens, if I adjust L5 and go back and check C7 or T12, and now they're more tender and more spasm, then I'm usually going to work on that visit, because the odds are they're probably going to get sore and start to hurt if I don't, especially if I'm going into the weekend or something like that. Like if I don't have the ability to see them in a day or two, then I'll be like, hey, I better go ahead and work on this one, because I know it's going to hurt. It just saves the problem of them trying to call you on the weekend going, doc, after you adjusted me, 2 days later, my mid back is hurting like I can't stand it. Well, if you know what you're looking for and know the changes that are going to occur, you can know when and when not you need to work on some of those, just to save the problems, So that, like I said, that just kind of comes by looking at that whole spine and doing your exam and analyzing those. So it takes a little bit of, 2 extra seconds just to check afterwards and say, okay, I just adjusted L5, and you got to pay attention to how, or even ask them sometimes, say, pay attention to how tender this T12 and C7 is. And you dig on it and say, just pay attention to how tender they were. And a lot of times they do anyway, because they're pretty tender. Then you go adjust and say, is that still as tender? And they go, no, that's not as tender anymore. Then I wouldn't touch it. But if they go, oh, wow, that's worse, then I would probably adjust it that day. That's the way I operate. That's the way Dr. Lander's always operated. If he saw that what he did improved a lot of things, he would just let it go until it was really bad. He would really try to focus on the majors and not work on a lot of those other problems that weren't causing symptoms at the time. And so he could just get that area better as quick as possible. Then as the other ones showed up, he would sort those out. However you want to do it, but the main thing is this, as long as you are keeping up with it. He was talk about just keeping up with the changes. That's all we do. We induce change. We keep up with the changes. We just follow the body through the healing process until it's all healed up as good as it can, whatever limit that is. And the more chronic they are, the longer that road is. Symptomatic relief does not mean healing. That's the big thing. People think it does. That's the consumer mentality, but we know that that's not true. So, we're here to do what the patient wants. And from a management standpoint, they don't want to get spinal correction. They just want relief. I'm okay with that. As long as I'm always their doctor, they're always going to refer to me, and they're always going to come back every time they have a problem. whatever they want goes. Okay. But I'm always going to give them the bigger picture and let them know, hey, this will get worse. But that's their choice, man. People are adults. They have to, they have to make that decision for themselves. So I've just learned that if you try to force them into your way of thinking, you're typically lose them. And if you lose them, remember, the greatest motivator of human beings is pain. And if they link you to pain for any reason, they're not going to, which means even if referring to you would link pain because, hey, I'm sending my buddy Sally, but he's going to know that I sent him. That's going to link pain. They won't refer. It's just human psychology.
Hey, Dr. Waller, Dr. White put in the chat, would you recheck the tenderness while they're on the table that you just adjusted them on, or would you bring them back to the chair and recheck them?
A lot of times I'll adjust them and check them right there when they're laying down. Like, let's say I'm working on them prone or whatever. So like on the high low, if I'm starting on the high low, yeah, I'll check it right there. But I will say though, in Dr. Landers figures, a lot of times sensitivity increases when they're prone. A lot of what Dr. Landers figured out, because he understood a lot of neurology, and like so this goes above and beyond the Gonstead work. It's an addition to it. We subtract nothing away, but there's a window into the nervous system that he called the central system, which is basically how spinal damage impacts the brain and causes global effects. So a good example is one of my earliest cases in practice after working with Dr. Landers and learning this. I had a 12-year-old girl that had back surgery scheduled, severe sciatica going down her right leg, couldn't walk on her leg at all. All her pain was eliminated by adjusting C7 because we did the examination and basically you like in gravity and out of gravity, the brain does different things. Gravity is the main driver of cortical influence, our mechanoreceptors. And when the patient's in gravity, you're going to get you're going to get muscle spasm patterns that are different than if you lay somebody flat. Okay. So he would check muscles, and if they show up in a certain pattern, you can know that basically at least a good portion of what the patient's suffering from is the way the brain's reacting to these subluxations. So like in that girl's case, she had very active central system problems. So her C7 was on fire. So the way Dr. Landers would manage it, if they had a lot of central system activity, he would start with the subluxation that was addressing that first and let everything calm down, on that visit. So I found that, she had a lot of central system problems, and I adjusted her subluxation and C7, and that's what was causing all the muscle spasms down there. I didn't have to work on that. But it wasn't because, I found justification for working down there, but I probably wouldn't have got anywhere because it was all just coming from the way the body was acting globally. And that's not every case, but you guys fix these cases too, and you don't even know it because you just don't know how to check for it. But it's something we've always all done, but it's just, and that's why, I think a lot of times why HIO works is they're impacting a lot of the central system type of cases, and they're causing global changes because it impacts them neurologically, you see. But not that everybody has an active subluxation. They're just creating enough central change to cause global muscle effects. So, like I said, it's just an invaluable tool that he kind of figured out. And he learned because his daughter had a real bad problem. I forgot exactly what she was suffering from, but he wasn't getting results with her, and he just remembered an old upper cervical guy said that, yeah, when you lay people on their back, their muscles change or something. So he started and he was a real analytical guy. He just started laying people on their back and just feeling for differences. And he, over the years, developed this idea of what was going on, of these muscle patterns, and to where it was when I took over for him. He taught me and Dr. Waddell it, and it's just a tool that we pull out of our toolbox occasionally. But I use a lot of the additional muscle stuff, like the muscle mapping stuff, on a daily basis, because it's one of those things. It's kind of like the scope. If you know how to do that with almost the accuracy of the nervous scope, I can just feel your muscles and tell where there's an active irritation or nerve irritation. And what's nice about it is it's actually a post check for me too. So when I adjust somebody, I check motion, but I also feel the muscles. If the muscle spasm doesn't reduce, I know I didn't affect the nerve enough. That's invaluable, and that doesn't exist as we know it. So it's one of those things that I'm willing to teach, but people just got to want to know it. So, but it's on top of Gonstead as far as procedure. I think it's another criteria we should add in, quite frankly. I've talked to some people in about it, but a lot of people don't want to add anything additional. I think Gonstead probably would have, but I don't know. It's just one of the things that we need to discuss more as a group. Because I said we can add more analysis in. I think that's a good thing. Clinical certainty. So, but that's not what we're here to talk about. So, what other questions you guys got? Anything. And as far as adjusting chronic subluxations, guys, that's what we need to talk about. All right. So when you got a disc like this, all right, it may or may not tolerate or respond like, you know, an acute disc. One thing that Dr. Landers did a lot of is, you know how I've taught you guys to manage acute disc, you know, that pumping mechanism. He would always tell the patients, he's like, hey, I'm going to work through this a little bit several times. And what he would do, he would get on it, you know, like on the, say he's on the high-low, he was kind of start putting some pressure in, give a couple kind of small little, you know, pumping thrusts before he set it, you know. And what he was doing is, you know, you think about what you don't see on the x-ray is all the scar tissue that's kind of locking this sucker down. And by doing that, he was kind of prepping those to all the soft tissues around it to accept that thrust. And when I started doing that, you know, you'll get a lot better adjustments on people and even a lot better change if by doing that a couple times prior to giving that set. So, you know, take it down, apply the pressure, lift that segment, kind of take it down and pump it a bit, you know, like mini thrust, but not like this, just kind of nice, gentle. Then that third one, you know, give it your regular set that you would do. And, you know, he just felt that was, you know, I don't know, kind of just warming that scar, that tissue up to be able to get through some of that scar tissue. Because that's, you know, what limits a lot of our corrections too, and why the knee chest is kind of nice, is because, you know, you get adjustments on certain people, and like the first few adjustments seem like they help a lot, but then you'll stop getting results. A lot of times it's because you're not getting deep enough to get that extra bit of scar tissue out there. You know, I mean, Dr. Alex used to talk about that a lot. You know, there's cases that I have that don't respond anywhere else other than the knee chest, just because it's a depth issue. You don't get it set deep enough to get all that range of motion or max, you know, enough to, you know, let that nerve have enough breathing room. You're not going to get the results. So that's why you get temporary results or partial results. But, you know, if you're not getting it set, you know, correctly, you're not going to get maximal results. You know, so when you adjust these chronic ones, you have to be kind of, you know, cognizant of the, hey, how are they going to accept, especially the elderly. You know, one of the problems with what we do as GONSA guys, we are so effective at creating change. You know, change can be a crazy thing if the spine can't accommodate change. Like that X-ray of that lady, all her adjustments were very light and pumping type of adjustments. I never wailed on that lady, because think about it, that spine's capacity to change is almost non-existent. Okay, architecturally, it's non-existent. All right, it's so degenerated, so much curvature that if you go in there and waylay on her and move that whatever it was, you know, this like she had a bad fifth lumbar, you know, you're probably going to throw her into a crisis, and you're never going to pull her out. Not in time. She'll never give you time, you know, because you're going to be hurting so bad. And that's the big mistake a lot of regular chiropractors make, because they don't X-ray, they don't understand any of this. They just go and pounce on people and just disturb everything, you know. That's why GONSA typically didn't want people to adjust too close together, because you're going to disturb things. You know, your technique's not clean enough to be able to get in there and adjust something and go a few segments higher and do that. You know, not that GONSA never did it. It just, you know, GONSA really didn't trust us, guys. That's why I always go back to it. BJ didn't trust us, because he knew we'd screw it. We were screwing up back then. You know, we adjust too hard, too many places, too often. So GONSA came up with best practices, and, you know, I think we should stick to those. Now, there's times you have to kind of do what the patient needs. That, you know, it's like, well, this doesn't, I can't find this in the chapters anywhere. Where do I do this? You apply the GONSA principles as best you can. You know, like I had to go see a patient today. She had COVID, and she ended up developing transverse myelitis, and she started getting tingling at her belly button. And then she's completely paralyzed from her waist down now. Now she's starting to get tingling and stuff in her face as well. She actually is in the hospital right now as we speak, but she got out of the hospital. They brought her in so I could see her, and she's got a real nasty, I think it was T9. You know, it's got lots of degeneration, stuff like that. And she had her L5 was on fire as well. And so I got her on, we had to launch her up on the high-low. We had help, both got our arms up. We put her up on the high-low, got it, you know, hit the button. So I used to take care of an MS patient like that. So here we just got her up on the high-low after I did the exam and all that stuff. And I adjusted the T8 and I did L5, and she moved her left foot after I did her L5 on the high-low. But she's in there now getting all sorts of IVs and stuff like that. So I don't know. I told her, said, hey, you got to do whatever you take. So, I mean, we won't know if this works or not, but, you know, as long as she's better, we don't care. But she moved her foot. They're like, hey, did you see her move her foot? That's great. That's awesome. But I think what happened is because of the swelling and inflammation, that extremely chronic subluxation at T8 is putting pressure on her cord. And so that's what they're trying to do, is they're giving steroids. And she got some partial results when they had her on massive steroids before, but it's because of that. I mean, she's got a probably a inch long bird beak sticking out the right of that T9, you know, because it's such a bad subluxation. The osteophytes are like way out here. So, you know, the stenosis that's probably going on because of that, just, you know, she's getting cord pressure there. And she also she did have a real horrible left occiput. So I set that as well, but I really didn't get hardly, I guess, got a little bit of improvement on the motion because that thing's like, it's frozen. So she needs some work up there. But what I'm thinking globally is that the compromise up here is making the entire, you know, anytime you have nerve pressure at any part of the nerve, like at nerve root, the entire length of that nerve is more susceptible to pressure and irritation. Well, same thing I think happens with the cord, is that you get pressure up at the top, everything down below is now more susceptible to any other damage. So she had the nasty occiput subluxation, which sensitizes the entire cord. Then she gets that major at T8, all right, and that just kind of made her go numb from there on down. And she's got a lot of other problems, but yeah, those are probably her majors, you know. So, and then another problem at L5. So, I mean, that's just how you have to work through a lot of those things. And you know, she's been a patient a long time, but she's a bad patient. She never comes in, and she gets COVID, and it just threw her system to chaos. So she'll be coming back, but you know, so I'll let you know how that goes. But it's just a neat case that, you know, but she's been dealing with this for 6 weeks. She's been paralyzed.
Hey, Dr. Waller, when you're doing the pumps, what if it's a cervical that you're trying to do in the cervical chair and you're trying to adjust a super chronic degenerative joint?
Well, I'll tell you guys, you know, I came to give you that prone seminar. I do more and more prone work, especially when it's like this on elderly people. You know, if you get somebody like that lady, you know, I mean, we could throw her X-ray up again. I wouldn't set her in a chair other than maybe her Atlas. I mean, it's not that you can't. I'm just saying the risks of disturbing. You guys got to realize it's a skill to be very clean with a cervical adjustment. You know, sound is sexy, but sound is also usually you rattling a lot of other stuff. And that's why when I talk about cervical chair, don't ever lean the head over. Like, I know docs that when they adjust their heads over like this and it sounds sexy, I won't let it be done on me. And you do that to somebody like that lady, the hornet's nest you're probably going to stir up will just be unimaginable. So to have technique clean enough to be able to set necks like that in a chair is a skill that most people won't achieve for decades, quite frankly, to be honest with you. I don't really like to do it, you know, but I mean, up in the upper, will I do it? If I need to, if I can't get it done prone. But nowadays, I check my ego at the door, man. I'm going prone. As long as I can get the job on those necks done prone, because first of all, you know, they actually like it better. You know, a lot of those old people just don't appreciate sexy adjustments. They don't. So it's better for them. So I do more and more prone work on those. So because I want to be as clean, I only want to influence that joint as much as possible. I want to not influence the other ones as much as I can. I got another neck. I should have brought the X-ray, but it's like the worst neck. He's got like 3 different spondylos in his neck. You know, and it's like spondylo inferior, spondylo inferior. You know, and this guy came in with bilateral hand pain and neck pain, and I had to work with this guy's neck, and it was all prone, and he did great. But had I sat him in the chair, would he have it would have caused more problems? I don't know, just because this is the mechanism. You have to be so good at stabilizing to be clean enough to do that. Why take the chance if you can do it prone? You know, I don't need to prove anything to myself. You know, I just want to do what's best for the patient, and I think prone is the best thing for a lot of these patients. You know,
Does that include side posture too?
What's that?
Does that include side posture too for a tough practice, or not as much?
Most of my elderly patients are prone patients if they're old and degenerated, unless they're not getting results. Like I had a lady who she's got multiple spinal surgeries, spinal fusions and stuff, and she had been doing great, but she had a fall this year, and it kind of really set her back, and her low back just was not getting better on the prone. So I said, hey, can you lay on your side? And you know, she's a golfer, so she's active, so she could. And I set her that, got that extra depth, and then she was fine. But You know, if you're not getting the results, then you have to take them there, but you just got to be clean. You know, it's just like, you know, people were talking about, you know, hip replacements. Can you, you know, I have a guy who's, you know, has bilateral hip replacements, and I was working with him prone. It's not that you can't never adjust a person with hip replacement, you know, with the artificial hip up, is that if you're one of those guys that's technique is bad and is kickstarting a Harley, it's probably a bad idea to put a hip replacement valve side up. But a proper pull and push puts no pressure on the femoral joint itself. Your stabilization should be on the ischium with your thigh pushing into the table. It shouldn't be driving that leg down. That's not proper. See? So who are you? Well, how's your technique? You know, critique yourself on that. You know, so if you do that, you can definitely see those people. That goes back to best practices. Gonstead knew a lot of people were kickstarting Harleys, and if he made that, oh, go ahead, you could do that. A lot of people have messed up prostheses. You know, he protected us from ourselves. See, so it's not that you can't do that stuff. It's just it's probably best practices not to do it. But can be done. Does it have to be done sometimes? Absolutely. You just can't get it moved any other way. It's just like learning to adjust everything in the cervical chair. I made that video one time. Did Gonstead teach that? No. Am I applying the Gonstead principles in a different way? Absolutely. It's all Gonstead, even though Gonstead himself didn't teach that in a seminar. You know, Dr. Landers taught it to me. You know, it's the Gonstead context, it's the Gonstead mentality, it's the Gonstead correction, just in a different form to get the job done. You know, not everybody's gonna get on a table. It's just the way it works. You know, I had an MS patient that for years we just sat her on the chair and we had to adjust a L5 at the assistant hold the knees, and I got under there and adjusting L5 in the chair. You know, because I couldn't. And then eventually we decided that we could figure out a way to get her on the high low, and we started doing what we did that lady today. But you guys have to solve these problems, and that's part of being a good Gonstead guy. Is you got to be a real good problem solver. You got to work these puzzles and be able to figure out what's going on. Because with these chronic ones, especially, you got to think about what could be limiting you. About how can these other subluxations play into that.
Thank you very much. Thank you.
What else? Yeah, but the other thing is just make sure you give people proper expectations. You know, when I talk about the patient psychology lectures, that the attitude I think that people receive you best is if you just like say like, hey, I'm your buddy next door. I'm gonna give you the no bullshit answer. You know, my hands are tied, but this is the way it is. You know, say, Bill, like I've had said this exact thing. A lot of people say, Bill, average spine, I can, probably have you out of pain and stabilized in, 4 to 6 weeks. I said, Bill, this ain't you. Sorry, buddy. I said, a spine like yours, stabilization is not even on the table. I'm gonna try to get you some relief, and I'm gonna give you 4 to 6 weeks to see if I can give you some relief. Okay. If I can do that, then I'll keep working with you. But you kind of put them in a position where like, oh crap, man, I'm bad. I don't expect results tomorrow, But if you go, oh sure, I'm gonna fix you up this week. You're gonna be playing football this weekend. You're setting yourself up for failure. It's like, patients are gonna be happiest if they're excited, which means you need to under promise and over deliver. You see, but if you don't get the time to do it in the first place, then you're just sabotaging yourself. So tell people tell them that you think it's going to take longer than you truly do, just for your own advantage. Say, hey, if you think you honestly can get them better in 4 to 6 weeks, tell them 6 to 8. And when you get them better in 4 to 6, they're ecstatic. You're cutting back care earlier, then they're telling everybody they know about you. But if you get them better in 6 to 8 weeks, they're still happy. They're not really excited. He did what he said he's going to do. It's just a psychology thing. Under promise, over deliver type. But yeah, I mean that's essentially it, man. The chronic subluxations is you do what you're trained to do. You just got to just look a little closer, palpate a little bit more detailed, and look for a few things that you weren't looking for. So, my recommendation is, guys, just start palpating out lateral. That's the first thing that you should do. Don't neglect palpating the entire spine, and start looking at your films and looking for these chronic discs, and then go in and start palpating those a little bit more detailed to see if you're missing stuff. And then you also, after you scope, see if you're missing some readings by then going down with the static palpation, finding some edema that doesn't have a break, then going back in and playing with the scope, scoping slower, you know, and because those readings can be little, guys. I mean, they can be really little, you know, to the point where you're like, is that a break? But, you know, it's there, you know. So I mean, it's just one of those things. Everything we do is subtleties, you know, the palpation differences, the field difference, it's all subtleties. And that's when you master the subtleties, that's why, you know, I always tell people the progression in Gonstead goes by decades. You know, at 10 years, you start to think you're pretty good. You got the hang of this stuff. At 20 years, you think you're pretty good at it. At 30 years, I think you're a Jedi. And at 40 years, you're like on your own level of the planet. You know, you're the master of your domain. So that's the kind of way I've seen it. So I'm looking forward to 30 and 40 years. But yeah, that's why learning from these guys that had 40 plus years of practice and being at the seat of Gonstead, you know, Dr. Landers was one of his first students ever. He actually was going to Gonstead before he was in chiropractic school. His cousin, Dr. Drennan, was actually the guy who got Gonstead to come to Texas for the very first time. And that was one of the first seminars Gonstead ever put on. So he got to go to that before he went to Palmer. And then he graduated from Palmer in '61 and was going to seminars all the time. And just, I said, every 3 months, he would shut his practice down and go see Gonstead and get adjusted 3 times a day for 2 weeks. And he paid for every one of those 3 visits. I think he got a little bit of a discount because he's a field doc, but he paid for every visit. You know, whereas now, how dare you charge me for, I'm a chiropractor. You know, everybody expects free care from everybody else, but Gonstead didn't give doctors free care. You know, not if you went to the clinic. There's not Dr. Landers, maybe he's an asshole or something. Yeah. But yeah, those guys just, you know, they just learned the palpation. I mean, they drove that stuff home, but they very rapidly abandoned all that. I mean, that's why, you know, that video of Dr. Gonstead talking about Billy Graham, Billy's like, oh, I was seeing Billy Graham. Billy's like, oh, I'm gonna start mentioning chiropractic at my preachings, and you guys are busy. He's like, don't do it. You know, they'll go to the treater practice. They're not gonna get what you got, and it'll ruin the profession. He says, don't do it. He goes, that's right. So it's just one of those things. But yeah. All right. Any last questions, guys? I don't have any more stuff. Unless you got questions about cases or something like that.
The one question I have left, many I've asked already, sorry, but is for case management, how do you normally start with how many visits you ask them to come in, how often for a chronic patient?
Right. So the average patient, you know, my care plans are, you know, like I said, I don't do hard, fast care plans. My patients know that these are just rough estimates. So if they don't have a ton of degeneration, they're not really old, they're not like that lady, you know, I'll ask for initial 12 visits over 4 to 6 weeks. So I see people usually, I tell people the most important part of my care for the first 2 weeks is simply the frequency, because if it's not moving, it's not healing. You know, and in my mind, that's the way I think it's true, because, you know, it's only going to heal if it's moving. And chronic subluxations, they're used to being stuck for the past 30, 40 years. You think you're going to adjust it once, it's going to stay moving for a week? Probably not. You're lucky if it's an hour or a day. So in my mind, you know, you want to see them about every other day, you know, 3 times the first 2 weeks. And in my experience, if you can get that from them, by the end of that second week, they're already doing much better. And then you can kind of scale back a little bit if you want to and carry on. And as long as they're getting results, they're going to give you whatever you need. Because even if it like takes it, because 12 is just kind of a ballpark number. But if you can get them to give you 12 visits to try, and it actually ends up taking 20, they're okay with that in my book. And most of the time, I've never had anybody balk. I'm just saying, hey, you know, you've done really good, but this area here is just taking a little bit longer. So, you know, I know we said 12 or whatever, but it's just unfortunately going to take a little longer, and nobody balks at that. As long as they're getting results and you give them the rationale. But if you go, I don't know why you're not getting better, but keep coming, they're probably not going to give you the time. You see? So just think like a patient would think. You know, what would you want to hear to give that doctor more time? And really, it's just an explanation of why hey, yeah, we're still on track. We're just a little behind schedule, and here's why. And usually, if you know, it usually goes back to chronic issues. I'll just say, hey, you know, this area is real chronic, or you know, this area here, this thing's so bad, it's bone on bone, and it's just, you know, it doesn't want to keep moving. But you know, if we keep working with it, it'll get the idea. You know, it'll start playing ball with us, and you get the time from them. So yeah.
Yeah. Thank you.
Anybody else have any questions? Chat or the audience?
Doesn't look like yet, but I did want to thank you very much for donating an hour and a half of your Sunday night. to be with us when you could be with your family and doing a lot of different things. So it really means a lot to everyone, and we appreciate it, really.
Thank
My
you
pleasure,
so-
guys. It was a lot of fun. So thanks again, Marcus, for doing it, man. Keep up the good work.
Yes, sir. We're going to keep trying to get this to as many people as possible, and now we're not held back as much. So it'll be good. So thank you very much.
Thank you.
Thank
All
you
right, guys.
everyone for joining too.
What's that?
Thank you everyone for joining as well. This was a
Oh,
great
yeah.
meeting. So
Thanks,
you.
everybody. Y'all have a good night.
Have a good night.
Thanks,
Bye-bye.
Doc. Bye.